Good morning, everyone. Thank you for joining us today for our first session of this academic year of our Global Neuroscience Institute Grand Rounds. Today, it is my pleasure to introduce our newest member of our GNI family, Dr. Negri Brito, who comes to us from Brazil, where she obtained her MD at the University of Pernambuco. Hopefully, I'm pronouncing that correctly, and completed her neurosurgical training at the same institution. She then went on to multiple fellowships, including in pain and functional neurosurgery, a neuro-oncology fellowship, a research fellowship at the Cleveland Clinic, and then a comprehensive adult and pediatric spine deformity fellowship at Mayo Clinic, followed by a pediatric neurosurgery fellowship at the Barrow Neurological Institute at Phoenix Children. She has numerous peer-reviewed publications, book chapters, and presentations at national as well as international meetings. Her current clinical focus, though, is and expertise is in the complex spinal deformity in reconstruction in both the adult and the pediatric world. Dr. Negri Brito, again, welcome, and thank you for giving us this talk this morning. We look forward to it.
Hi, everybody. Good morning. Thank you, Dr. Ramin, for the kind introduction. I'm going to go over a little bit about sagittal balance. There will be a lot of numbers and a lot of angles. I know that the audience is kind of mixture. So I just want everybody to focus on the main concepts here and some of the main ideas that I'm going to go and then discuss a little bit as we start the talk here. So just some of the goals for today. Going to discuss a little bit of the sagittal plane development. Then I'm going to talk a little bit about the concept of the cognitive economy, which is very important. Going to go over some of the previous alignment schemes, some of the new concepts for the normal sagittal alignment in terms of for planning and surgery, and also the goals for surgery. So let's start here with a little bit of history. We all know that humankind took actually millions of years and to developing into a quadrupedal to a bipedal position. It is that pretty much that bipedal position that gives us the normal curves of the spine. And those are the normal curves that we try to respect so much whenever we have like any surgery, any deformity surgery that we need to correct and restore the normal alignment or the normal sagittal balance. So this is just to kind of emphasize that the millions of the years that we took in order for us to have those natural curves in our spine, just because we're standing. And it also helped with me explaining the concept of cognitive economy. But also, like as we start like walking and as babies, we also just emphasize that natural normal curves of the spine. As the baby here, then when the baby starts to kind of position themselves up with both hands, and then when the head starts moving up so the baby can see, that's how we get the normal cervical lordosis. Whereas when the baby starts crawling, then we see that in the picture too, we get to see the development of a normal lumbar lordosis. So this is all part of our development as human and also for our spine. And then that will bring us to this important concept here, which is pretty much the cognitive economy at Dubusse. So in general, it's pretty much every time that we are standing, our spine has to be in line with our heads, hips, and feet. Why? Because pretty much every time that we're standing, if we keep that alignment, I will be saving energy, meaning that everything that can go against my position in terms of the spine, and then my spine relative to the head and the hips and feet, can give me a tremendous waste of energy, and I can kind of exemplify that. Let's say you have a patient, when you see that the patient's kind of curved like forward, and then he's trying to walk, that patient is wasting a tremendous amount of energy just because he's out of that cone of the economy there. So it's a theoretical model. Pretty much demonstrates the optimal zone, which the spine can be aligned. And also, as I said, there must be a balance between our cervical lordosis, the normal thoracic kyphosis, and lumbar lordosis, our pelvic incidence and lower limbs. Pelvic incidence, I'm going to go and discuss a little bit of this in the next slides. This is going to be one of the important concepts that I need you to kind of focus for the presentation. And then again, every time that you're not on the cone, every time you have a patient that are not on the cone, there's usually a frequent surgical indication, because either the patient is leaning forward or they have some position that I'm going to discuss this, our natural plumb line is a line that we're going to have to draw. And then if whatever I kind of balance off the line, that means that I'm wasting too much energy in order to walk, in order to sit and do the normal activities on a daily life basis, on a daily life. So here are some of the previous classifications of the spine. So it is very important for every type of the deformity surgery. We need to have an idea as to how the spine of the patient is behaving, because that would guide us, one, the decision to operate or not, and two, if we have to operate, what kind of surgery and what kind of construct we need to do. Basically, all of the previous classifications that we had for deformity in spine were all based in adolescent and even pediatric deformity, not all based in adult spinal deformity. Some of those previous classifications I'm going to discuss a little bit here. We're going to discuss a little bit of King-Moe and Lanke. King-Moe, for instance, was one of the classifications of curvatures of the spine that have been for 20 years, that people have been using for 20 years, but it was not very helpful. You can see those types of the spines there. There are subclassifications. They used algorithms. It was just not practical at all. And then also most of the cones for that, it was not comprehensive. They had a big failure to demonstrate scoliosis, a three-dimensional deformity, because here I'm talking a little bit about the sagittal, but whenever we have to talk about spine, we have to understand that it's also a sagittal, but also a coronal deformity. And we have to see the patient as a 3D, not only as a sagittal deformity, as all of the classifications in the past were taken into consideration. So again, Lanke and colleagues, they try to kind of improve that, but you can see in that big square there that you have curve type, and you have structural criteria, you have location of the apex, you have the lumbar spine modifier, all of those things that, okay, they helped, but still they failed to understand scoliosis as a 3D deformity. They only took into consideration the sagittal plane. Okay, so you might going to be asking, okay, but the talk today is about sagittal balance. Isn't that important? So shouldn't we be talking? Yeah, so sagittal balance is still very important. This is just to exemplify that it's not just that. And then classifications in the past used to take only that into consideration. So Lanke and colleagues, it helped a little bit, but they didn't do the whole thing yet. So let's go over the next classification, which would be Schwab's. So Schwab's helped a lot. Actually, Schwab's kind of introduced the sagittal modifiers, and those are the three things that I would like to focus for this presentation, which is pretty much the pelvic incidence, global alignment, which is the sagittal vertical axis classification, and also the pelvic tilt. All of those three things, all of those three main ideas that Schwab introduced to the classification are the main topics that I wanted to just remember that as I'm going forward with this presentation, because those are pretty much the parameters that we're going to have to take into consideration, even up to date, whenever we have to do a correction of a spine deformity. So Schwab was pretty much the first that integrated those radiographic parameters, those new ones for the sagittal modifiers. And also, he was the first that correlated with the quality of life, because we have to, whenever we propose a surgery, you have to propose a surgery to a patient that can help him somehow, and then can help in any way to improve his quality of life. Most of the time, those patients have pain, they have chronic pain, they can't walk too far, they can sit for more than 20 minutes. There's only one position that they can feel comfortable, sometimes none at all. They can feel comfortable to sleep. So whenever I have to do surgery, we have to think about that. So quality of life is very important. And Schwab was very successful because he was the first one to include that in his classification. So as I said, the main topics here, if you want to just remember like the three things about this presentation, remember about pelvic incidence, sagittal balance in the sagittal vertical axis, and then shapes of the pelvis. So Schwab's introduced the sagittal spinopelvic alignment concept, and we have the pelvic incidence, we have the measurement of the pelvic tilt and the sacral slope. Those are very variable in the population. And then those are the things that whenever we have to do a construct to fix any spinal deformity, those things we cannot change because they're pretty much part of the anatomy of the patient. They're part of the development of the spine of the patient. Well, I can change lordosis, I can change kyphosis, but I cannot change pelvic incidence. But I have to take into consideration that whenever I'm doing construct. And also the sagittal balance there, you can see that there's a guy with a line there, we call it a plumb line. It's pretty much that whenever I see a spine, it's like I'm seeing like a building, and then I kind of trace this line and top of C7, like in the middle of the body of C7, all the way down to the sacrum, and I can see the shape of my spine there. So whenever I have like my spine either going forward to that line or past that line, I can have either positive or negative sagittal vertical axis, meaning that I can have the patient kind of going kyphotic, more kind of going in this way, or I can have the patient trying to, in order to maintain his cone, remember the cone of economy, in order to keep his spine in that cone of economy, the patient's becoming more lordotic to kind of bring the pelvis forward and then try to save energy. But he's not doing a good job because you can see that when the way that he does that, the patient kind of becomes very unstable, and that's when the sagittal balance gets into the general idea here. So again, coming back to Schwab's classification, he was the first to recognize the spine deformity was a 3D model. Also, he was the first to do a kind of put in those three main ideas of the pelvic incidence, SVA, and also the poor quality of life. Also, he added that pelvic incidence that up so far, nobody had done that before. Also, he was the first, as I said, the first to manage the three categories of pelvic incidence, SVA, and pelvic tilt too. Those are all things that we cannot change. But also, sagittal vertical alignment, remember that line there, the plumb line? It's a poor measurement of sagittal alignment. Like, I can only see either if the spine is going forward, it's going back, it's neutral. But in the reality, sagittal vertical axis can only tell me, and it's like a prediction of a comparison of the patient last or future sagittal plane, meaning that if I have a patient that is going forward, I have that line there, and the patients have like a positive sagittal vertical axis. I operate on that patient, and then he's back, he's neutral. Okay, I have that in comparison. I brought that patient back to the cone of economy. So, but it's not a very good measurement. It's a poor measurement. I can only take sagittal vertical axis into consideration just for comparison. And then that is one of Schwab's trying to get SVA as a predictive value for good measurement of alignment, but it was not. But also from Schwab's, we knew that we started learning that categorizing continuous variables can also be a problem, because if you take a look into Schwab's, it kind of goes into, he scores some points into less than 4. Let's take into consideration sagittal vertical axon, less than 4 centimeters, 4 to 9 centimeters, more than 9 centimeters, and then that happens with the other parameters too. Those continuous variables are kind of hard when you're trying to classify and then try to make some calculations for your patient. So talking a little bit about Chomsky-Molenki, let's go now to Russolli's classification. So Russolli is very important because our main concept of the spine is that everybody has like a cervical lordosis, then a thoracic kyphosis, then the lumbar lordosis, which is very much segmented in the lumbar, and I have the thoracic kyphosis, which is segmented between T1 and T12, and I have the cervical lordosis between C1 and C7. And then what if I tell you that it's not true? It's not true like for every patient. Like every patient, every person has its own spine profile, had their own spine profile. So it kind of changed. And Russolli was the first one to actually show that. So in this paper here, he did a cohort of 160 asymptomatic patients. And then the first paper, he actually was able to show us 4 sagittal profiles. And then maybe then later on, he kind of put in about 5 subtypes, as we can see here. So he separated those 160 patients into a low-grade pelvic incidence and those with a high-grade pelvic incidence. And then why is that important? Here, you can see that let's focus just on the 4 classic types. So you can see here in the type 1, low pelvic incidence, I have a low sacral slope, and I have the apex of the lumbar lordosis in the L5. So the sacral slope here is less than 35 degrees, which is also associated with the low pelvic incidence, and that apex of the lumbar lordosis is in the center in the L5. So I have a low arc of lordosis there, and then also negative lordosis tilt. When I go to the type 2, also with a low sacral slope of 35 degrees, now the apex of my lumbar lordosis is no longer L5, but L4. And then there's also a lower arc of lordosis, kind of flat. If you look at that profile, that's like a flat, the whole flat spine there. And also not only is hyperlordotic, but also hyperkyphotic too. When I take a look into the types 3 and 4, those are all with the high PI, higher sacral slope. You can see that the sacral slope of the type 3 goes between 35 and 45. The apex of the lordosis is also centered in the L4 vertebral body. There's a more prominent arc of lordosis there. And then the spine is kind of well balanced. So let's say that I have a type 3, it's like the normal individual. If I'm going to trace that plumb line there, the SVA line there, there's going to be like a very harmonious spine. When I take the type 4 here, also a higher sacral slope, I have a higher angle there, more than 45 degrees. I have a high PI2. Remember, the center of the lordosis up to the type 3 were all centered in the lower lumbar body. So I have L5, then I have L4, then L4 again. But now when I see the type 4, the center of my lordosis is going to be up to L3. But in the arc of the lordosis is more prominent too. So you can see that there's like almost like a hyperextension there. And it's been known that this type of spine is more prone to disc degeneration and disc disease and then disc herniations and then pain. So you can see here, like as my pelvic incidence gets higher, then the normal center of lordosis kind of change, and also the arch of my lordosis is also changing. But yeah, but you're gonna okay. So why is that important? Like I don't see why like Russolli. Okay, Russolli showed me that kind of angles, that amount of pelvic incidence, but why is that important again? So he actually he knew the importance of the pelvic incidence and the sacral slope for alignment. Remember again, I cannot change pelvic incidence from the patient. These are things that I cannot change. I have to take that into consideration when I'm building the idea of my construct here. Also, the sacral slope and the shape of lordosis. So classically, if I measure L1 to S1 as my lordosis center, it can be only true if the inflection point between my lordosis, my lumbar lordosis, and my thoracic kyphosis is between T12 and L1, meaning that many patients, the classic measurement, the classic idea of me having a kyphosis between T1 and T12 cannot be true. Some patients, I have a kyphosis situated a little bit lower between T4 and T12. That patient with depending on the sacral slope and the shape of lordosis and the shape of lordosis, I have my kyphosis a little bit higher, a little bit low. So that is important when I see the profile of the patient, when I see the spine, and I put into classification. If I have to do a construct, I have to respect that, because otherwise I'm in a great danger of having a failure that, and a patient can keep having pain, or my construct can fail. So I have an example. The patient is very kyphotic in T12 L1, so it's very kyphotic there. My lordosis change. It's no longer between L1 and S1, but the center of my lordosis is lower. It's now between L3 to S1. If you take that type 4, for instance, it has a lot higher lordosis. My center is L3. It means that if I have a higher lordosis, you remember, I have to somehow my body will adjust to the economy. That kyphosis would be a little bit more exaggerated. So this study kind of demonstrated that the alignment of the human spine and pelvis in the way that was standardized is highly different and highly variable for every individual. So we have to take that into consideration too. And also, there's this other study, which is pretty much the predictive power of the Russell classification and also the mechanical complications. So in this study, it was actually based on 10 retrospective studies, more than 1,400 patients, and they pretty much compared constructs done in spines that respect Russell's ideas and the ones that didn't respect that. So we have the matched group, the ones that respect that, and the unmatched group. So you can see that what they found is that in the matched group, the one that they respect the Russell's, there were more, the one that they didn't respect, sorry, there were higher rates of posterior proximal junction kyphosis, meaning that the top of your construct can become kyphotic, and also more rod breakage than compared to the unmatched group. So matching the patients to the ideal Russell type in an adult the adult spine deformity can reduce your mechanical burden also, and also the amount of pain that the patient is going to have in a post-operative scenario. So we discussed a lot of the classifications and important concepts here. So let's talk a little bit about the goals of surgery. So many of the classifications in the past and many of the that we had so far did not take into consideration age. Age is very important also for our alignment, because as we become wiser and more experienced, our spine changes too. So we need to take those change related to age into consideration. Remember, everything that we do, the initial aim is always to provide a better quality of life and improvement of pain for the patients. So this paper basically they try to determine if some age-specific parameters put taken into consideration into realignment threshold for adult spine deformity. So they pretty much use the OS3 disability index, which kind of score. It's a test when you score physical limitations caused by back pain, whereas the short form 36 is also another test, which is going to be scoring mental and physical capacity. So they put those two tests together, and what they pretty much realized here is that some of the patients, as they get older, some of those parameters are going to change, meaning they're going to have higher SVA, they're going to be getting higher PI. And then the main idea is that if I have a older patient with a higher high SVA and a young patient with a high SVA, I can be more aggressive in my construct in that younger patient and comparing to the old patient. So it pretty much showed us that the sagittal spinopelvic alignment varies with age. This is something that we knew, and we know, but no one up to this study kind of incorporated that. So all objectives in realignment should take account for age. And then age is not static. And then we see here, let's see here, like those two x-rays that we see, the patient on your left is 65 years old, the patient on the right is 66-year-old, so they're very matched in terms of age. And you see like the baseline here, like a very the patient's kind of curved, very kyphotic patient there. We have in the second patient pretty much like a flat back there. We can see that the pre for the post patients, we can see a pre for the patient on your left, a PI, a high PI of 42, a pelvic tilt of 27. You have look at the plumb line there, the SVA there, it's like 186. And you can see also the patient on the right here, a PI of 25, not so high, a PT of 27, kind of very similar, but not so high SVA of 71. The patient's trying to compensate that, maybe a little bit more low doses there. And you can see those are the post and age adjusted. So what this paper did, and it is also a criticism to this paper, is that they had some parameters and they had some numbers to adjust, meaning that they have the pre and they have the age adjusted. So you can see that whenever you compare pre and post angles here, you have one that's overcorrection by age, even when they compare to the numbers that they had as parameters for that adjustment, and you can have an age adjustment alignment. So one of the criticisms of these papers, they came up to numbers. They came up with these numbers for correction, but the mathematics here is not correct because they not took into consideration that spine degeneration is multifactorial. So it can only partially be attributed to age. They go hand in hand. So age and spine degeneration, they go hand in hand. They did not consider spine degeneration as a critical component. So you have a patient that, according to those numbers that they had, was overcorrected, and then the patient on the left, according to the numbers of the head, I'm not sure that they did a good job there. So this is like, they were right to say that age is not static, but the numbers that they came up with that paper are not very correct. So it's a multifactorial thing. Also, this paper here is very important. This is a paper that kind of showed the role of sagittal alignment in predicting failure. And we see here that they kind of developed more than 300 models in the computer here, all in a T10 to S1 construction. And the comparison was the complication for major failure of the group, which was defined by rod breakage between L5 and S1, failure of S1 screw, and prominence of iliac screws too. So you can see here what is the red is kind of where there is more torque, more power, more strength in there, more compression. And then they pretty much saw that whenever we had constructions that did not respect the curve or did not give the patient the numbers or the angles that they need, those constructs were more prone to failure. So undercorrection here led to persistent compensatory mechanism. So you can see that you have most of the patients where you have rod breakage or screw pull out. Those are all patients, screw breakage. They're all patients that are undercorrected. So this is also something that we need to take into consideration. And then again, okay, so I have all those ideas. I know that age is not static. I have all these numbers. I have the PI. What about is there anything that can help me kind of predict like whether my construct is going to be okay or not for the patient? So then it came up the global alignment and proportion score, which is a new method for analyzing spinal pelvic alignment. We all know that the restoration of a normal sagittal alignment is one of the critical goals in adult spine deformity. The Schwab sagittal modifiers, remember those three main things that I discussed a little bit in the beginning, were very, like, they have been accepted and they are well accepted. But addressing those targets does not always prevent mechanical complications. So they came up with this gap score, so we can have an idea as to patients that are more prone to complication. And then with that, they introduced some of those new measurements here, which is pretty much the relative pelvic conversion and the relative lumbar lordosis. Those need to were taken into account in order to have that prediction. So GAP, as a single comprehensive score, it comprised of pelvic incidence-based proportional parameters, and then also better correlated with the health-related quality of life scores. And then also it predicts some of the mechanical complications compared to Schwab modifiers. So you have all the parameters here: relative pelvic conversion, relative lumbar lordosis, lordosis distribution index, age factor, remember important age factor, sorry, and also relative spinal pelvic alignment. We have all the scoring, and you have the categories. So we can have a proportionate patient, a moderately disproportionate patient, severely disproportionate patient. So all of those are gap scores are also another two that we can take in, we can use in order for us to help predict in our construction, and also if the patient is going to fail. And then again, it's all about visualizing and all about having construction. So Rusuli told me that not everybody has a lumbar lordosis between 1 and L5, and a thoracic kyphosis between T12 and T1 and T12. And that transition between thoracic and kyphosis can change depending on the shape of my spine. But also all of the other papers that I had up so far, they all included disease population, meaning people that have problems and issues with the spine. We didn't have any papers up to this one that took into consideration normal spines, because with the normal spines we can have normal variants, and we're more able to see what's going on with the spine changes. So this paper here, some of the methods that utilized was to kind of see sagittal balance as a definition using the vertebral body tilt and also spinal pelvic alignment. They had some of the measurements, and I'm not going to go over with a whole amount of measurements that they have in angulation. But what they found is that whenever we have to bring that patient back to the corner of economy, lumbar lordosis is not sufficient for that, and they were able to come up with two angles, which is pretty much the L1 pelvic angle and the T4 pelvic angle. Those are the angles that are important when you need to make calculations and bring that spine back to the normal sagittal and balance and alignment. So there were some correlations also between L1 PA and then T4 PA in order to correct that. That were all. This study was done using 320 normal volunteers, and then also the pelvic incidence was an inadequate measurement to estimate normal lumbar lordosis. Meaning, then we have to take in pelvic incidence into consideration, but that is not sufficient. The one thing that we're able to find in this paper is that whenever we need to have a normal sagittal balance, we need to take those two angles, which is pretty much L1 PA. L1 PA we correlate with T4 PA, and I'll show an example at the end of this presentation here, just for the sake of understanding. And then because of that, in this received another operation curve. And then they did a regression, linear regression analysis here, and they found that whenever I have those two angles kind of meeting together here, as I have in this the patient in the middle, whenever I have that patient's within the cone of economy. So it means that whenever I calculate my L1PA, it serves for me as an idea to bring the patient. Remember, whenever the patient is out of the cone of economy, I can always bring him, depending on the angles, the result of the angles that I have there, I can always bring that patient back to the cone of economy. So up to this paper, we had that the definition of lumbar lordosis as a function of my pelvic incidence, and then and also the L1 pelvic incidence had a higher variance. Whereas if I take the T4PA, I have a near perfect correlation with my L1PA measurement. So I'll go over that in a few minutes again. Here, again, this is from the same paper. We have two X-rays there. The last patient was pretty much like comparing the two volunteers, showing the difference in the vertebropelvic angles and also the pelvic tilts. You can see that one patient has a higher pelvic incidence and the other one has not that so high pelvic incidence. And now we can see that some of the patients, they try to compensate that either with a more lordosis or more kyphosis, but only a normal lordosis with an appropriated L1 pelvic angle results in an aligned T4 L1 hip axis sagittal balance. So this is another thing that will help me with the construct. So getting to the end here, we have this case. This is one of the cases from my fellowship. This 69-year-old lady presented with a low back pain. 80% were coming from the back. 20% was from the radiculopathy. The left leg was worse than the right. We had some diminished strength there in the right quad. She had a prior L5S1 Lamy. She had a fusion. She had also extension 1240 in 2012. She had also hardware removal and fusion again in L2 and 3 in 2012. Actually, the one is 10 years previous. And then she failed medial branch blocks. She failed epidural injection. She had only 50% benefit with SI joint. And then if you look here, this patient, again, just remember those three previous concepts of pelvic incidence and a surgical vertical axis and then a pelvic tilt. And you see that she's tilting like she has like a tilt in the back there. She's more kyphotic. If you kind of trace a line that, you can see that her prop line is negative, meaning that she's back there, she's not being able to bring that spine forward and then bring her forward to the cone of economy. And again, as I said, spine deformity is not sagittal. You must take into consideration also the coronal view. And you can see that she's got like a scoliotic curvature there. She has some thoracic and also lumbar too. I think that she has, if you take a look here, like she has a little bit of the hip coronal. You can see the hip imbalance there, kind of one hip going a little bit higher than the other. This is something that we also take into consideration whenever doing a construct. And you can see the previous surgery here with just the two screw, the previous vision that she had. But she's not, you can see she's not harmonious at all. Don't look at those angles there, but I'm gonna go over. But just see how bad she is in terms of alignment, and then the amount, like the great amount of energy that she's spending to keep herself standing on a walk, and also pain. So remember that L1PA from that paper? So this is just a formula that we use to calculate. She had those angles before. So she had a current 27.7 degrees of lordosis. So she's not lordotic at all there. And then when we calculate the L1PA, which would be our target, that number was 9.58, 9 degrees, let's say the 9 degrees lordosis. What does that mean? That means that that patient, I have the plumb line here, her lumbar lordosis here. I have to give her lordosis in order for her to go and fit into that cone of economy. So she needs 18 degrees of lordosis so she can have the normal, like her normal, considering like taking into consideration her spine, sagittal balance. And also remember L1PA and T4PA are very correlated. They have a near perfect correlation. It means that her previous T4PA angle, T4 related to hip axis angle was 32 degrees. So remember that whenever I got that target here, 9, will be the same one for here. So the 32 degrees does not equal the 27, the current 27 that she had her lordosis in the past. So she would need around 5 degrees when I kind of put this minus this one, she need a 5 degree reduction of the thoracic kyphosis. So I need to bring her lordosis like this, and I need to reduce her kyphosis in about 5 degrees. And this is the construct that we did. We had a T10 to pelvis constructed there. We have a new L1, L5 lumbar lordosis of 48.2 degrees. So she was able to gain here 19.2 degrees of lordosis. We had to do some maneuvers with some osteotomies in order for her to gain that amount of lordosis, because just with the instrumentation that was not possible. We need to do some of the osteotomies and PSO. And also she look at how like more harmonious she is right now. And also when you look into the coronal, she's pretty much aligned now. And now we also had to kind of put another kickstand run to push the other hip down so she can have like an alignment in terms of the hip too. So remember, sagittal deformity adult is usually not axial, and it's not only coronal, it's sagittal and coronal. It's a 3D deformity. So you can see how improved his spine is after this construct. Of course, we took into consideration age, we took into consideration the surgeries that we had before, we had planning for her in terms of the construct that we had to do, and then that patient did pretty well in a post-operative like a follow-up. So this is what I wanted to. I know that was a much of like a mathematics and angles and numbers, but if the main concept is well understood, I think I got some of my goals today. This is pretty much it. Thank you. I'm gonna stop sharing.
Thank you for this fantastic talk. For everybody, you can put your questions in the chat or in the Q&A. Also, the link to claim the CME is in the chat. So, there's a lot of talk of the sagittal balance, the plumb line, the cone of all the stuff that you talked about. As a primary care or as a general practitioner or somebody, they see a lot of patients in and out every day, and we as neurosurgeons, we see those as well. With just they come in, I have back pain, right? You get the imaging, they're standing a bit forward, leaning forward. When does that primary care trigger that point to say, okay, well, you need to see a spine deformity surgeon? Is there something they need to know about that, or is there a failure of certain amount of treatment before they send them to see you?
Yeah, good question. I would say that whenever you find a patient that's that kind of economy, I think that helps a lot, because whenever you see a patient that's kind of going out of that, you see a patient that's like too much kyphotic, which is, I think it's the easier way to find, is usually when they lean forward. And then this is something that, okay, so this patient's leaning forward too much pain, quality of life is bad. Please send this patient so we can have an eye on it. And then also, I would say that patients that they seem okay when they're standing, but the pain is too much, or you have sometimes you have like a CT or MRI that doesn't show that much, but there are like some arthritic facets, or you have like some degenerated disc that kind of, I don't know what's going on here. I would say, please send the patient over because we can take a look. But it's, I think whenever you find that something is going on and the patient's way past the corner of economy, I would say that having us taking a look at that helps a lot.
So another question is, more in the adolescent and the pediatric world, a lot of kids as they grow up, they have a little bit of curvature, and most of them it's a little bit balanced curvature. So, how do you follow these kids, and is there a way to tell which one of these kids is going to need the spine deformity surgery and which one is going to say, well, no, you're going to have a little bit of curvature, and how does that project for their lives in terms of having back pain? Everybody has back pain, but in terms of having severe back pain that's going to need management at some point.
Yeah. So most of the kids, we can try conservative approach, and most of them will be fine, like just with the brace. Um, we had kids like just fixing the curvature just by wearing brace. We usually tell them, like even for the spine, and then lower curves too, curves like lower than up to 20 degrees, you can have like full correction of those curves. But we always say is that whenever that curve reach 40 degrees and higher than that, that would be curves that we need to probably intervene, because that would be difficult to stop that curve from progressing in children. In adults, we always say that curve, whenever like there's in an interval of a year, if you have already, let's say you have like a 35-degree curvature, and in a year, that curvature went from 35 to 45. Whenever have like more than 10 degrees in a year, that's considered for surgical approach. In children and in adults, that curves tend to kind of increase about 5 degrees a year. Most of the children, as I said, whenever I have like up to 20 and 30, we try to treat conservatively with a brace, and bracing helps a lot. We always tell them wear like at least 20 hours a day, and then you have those kids like correcting the curve. Whenever we have that curve getting worse, and then I would say like a cutoff of 40, then it means that, and we have patients coming in with 45 or 50 degrees. It's also in danger to the patient, because the curvature becomes so great and so large that they start not only having pain but having issues with breathing, and then also because pretty much all your like your thorax, your cavity kind of changed in position, and this is something that is not acceptable like for any patient. But in general, the general idea is like smaller curves. We can always treat conservatively.
So, when you're looking at somebody, let's say a patient comes in with just regular, I don't want to say regular. If we see a lot of patients who have lumbar degenerative changes, maybe a bit of like grade 1 spondylolisthesis, or maybe a little bit of slip disc or whatever it might be. But they're also some of them tend to lean forward a little bit. Some of them have they don't have a proper sagittal balance or coronal balance. How does that affect your management of that specific, they come in with radiculopathy, let's say, and then they need maybe a fusion, maybe it's a little bit more than just radiculopathy, there's facet arthropathy, and then they need a fusion. How does do you take into account the sagittal balance when you're doing that single level? Do you know, or how is fusing that level going to affect their next surgery that is needed, or their sagittal alignment that coming down the road?
Yeah, we always try to, let's say we have a patient with like I said, like a grade 1 spondy, and then some disc degeneration there. We always try like some conservative approach, medications, physical therapy, weight management. We can exercising. We also can try like injections, medial branch blocks, steroid injections. Those are the things that we can try in the beginning. But let's say that patient's having intractable chronic pain, surgery can be something that we can offer. In terms of alignment, whenever I do like a focal instrumentation, my idea is only to kind of restore that anatomy, the normal anatomy of that focal segment without disrupting the rest of the axial spine or the axis actually. So whatever I have to do, I just do the minimal in order to get the patient rid of that pain and then restore that functional or the near functional anatomy that you have there. And that is why I don't think, and that is why I think that sometimes you don't have to, we see bigger constructs and bigger instrumentations for sometimes like lower segment disease. And that I think can disrupt the quality of life in that patient. Because sometimes we see that patients with a flat back that get bigger constructs when in theory that patient will not need to have any surgery or just conservative management or just injections. But whenever I have like a small segment, I usually I take into consideration, let's see, like a lower, like a lumbar surgery. I take into this consideration the whole position of the pelvis. But I like in my training and my point of view, we don't do those big calculations. We try to work locally and in a good way to restore that anatomy or kind of going and then decompressing the root or whatever we can find that's compressed there.
When you have a focal spinal pathology, you know that if I address that pathology, most patients will get better. For example, if you have a disc, if you take the disc, if it corresponds to the dermatome, to the symptoms, it's going to get better. If you have facet arthropathy, you say, okay, well, I'm going to try injections. If the injections work well, maybe you need the radiofrequency ablation. But when you have somebody who has a full deformity of the spine, you're going, thoracic all the way down to the pelvis. How do you counsel patients? How do you tell patients, that doing this surgery is going to help you with this amount of pain, or what is the likelihood that your pain is going to get relieved by going? And because we know these surgeries are not. They're not easy to tolerate. They're long surgeries. They're very prolonged recovery. Patients stay in the hospital for a prolonged period of time. Even going home, it takes sometimes 3 months for them to go back to a little bit of their normal routine. So how do you counsel those patients in terms of how likely their pain is going to get better? And is there a way for you to know which patients will respond better to the deformity correction versus others?
Yeah. So I always try to show the patients pretty much what they have now in terms of imaging and what are the goals of the surgery, what we're going to do on the surgery, the amount of pedicle screws or the amount of rods or the amount of decompression that we had to do so the patient can understand better that this probably is going to be like a huge surgery for the patient. But I always say that this is something that is needed, otherwise we wouldn't be proposing. If the patient, let's say it's a very kyphotic patient and we have to reconstruct that, I always try to show and say, hey, you need this construction, let's say like for, I don't know, maybe a T12, a T3, 12, and then because of that, I can restore your normal, near-normal anatomy, and I can reduce your scoliotic curvature, or I can reduce your kyphosis and then bring you back to that harmonious spine shape. And that would bring you a lot of relief of pain. And I know that because I have like a ton of literature to back me up. And I try to kind of go over with this with the patient. But also I think that I would say that most of the patients, 90% or maybe 95% of the patients that we had to do longer instrumentation and longer constructs, they're all very pleased with the results, even with the tremendous amount of pain that they had after the surgery, even without the difficulties after the surgery. Because I think that what brings most of the good results is the patient understanding. Like you've been able to transmit to the patient that the patient needs that surgery, what are you going to do? And the patient understands that that is needed in order for them to feel free for pain and then have their quality of life back. I think those patients that if they're able to understand that, I would say that the issues with post-op and the issues with then understanding the surgery are going to be like way better than them. Then you just say, hey, you need surgery, and then that's here. Let's book the surgery and do the surgery because I say that you're going to have to need this construct, and then they'll not answer any patient's question. I'd say that it's one of the important main topics to discuss with the patient.
Well, thank you very much for that talk, Dr. Negri Brito. And I have to say that your background into both pain and functional as well as spine deformity gives you this unique perspective and approach to patients with back pain and who pretty much are 90% of our population who have back pain. So I think we welcome you into GNI, and I think our patient population will benefit tremendously from your expertise. Thank you again. Thank you, everyone.
Thank you.
We will be again. The CME is in the chat, and we have a full season, academic season ahead of us. We'll send the emails when we get closer to the appointments. All right. Have a good day, everyone, and again, thank you.
Thank you.